The other thing is, if you have any questions during the panel, just throw them in the chat. Michelle and I will be going through that throughout the night, and we actually have some time saved at the end for a Q&A, so we'll just hold off on your questions till then. But now I'd like to hand it off to our president and dean, Alicia Ouellette, for some opening remarks.
Thank you so much, Jessica and Michelle, and congratulations to OUTLaw and the Health Law Society for putting on such an important and well-organized event. This is really an important topic, and it's something that the law school has been, a conversation that law school has been engaged in for a long time. Professor Connors was reflecting with a former student about some of our prior symposiums, but it's very current as well. I'm really interested to learn how COVID has affected the HIV positive community. It also strikes me that some of the issues that we're really struggling with regarding COVID are things that we kind of tested when we first encountered HIV. Some of the uncertainty, about the disease, about the drugs, about how to release them, consent issues, testing, confidentiality, contact tracing in the context of HIV. We learned it all a long time ago, or experienced it, and we learned from it. We continue to learn from that experience today. It also strikes me that the history and experience of those who have lived with HIV is important to understanding current issues that are faced by HIV positive, the HIV positive community today. The past, it was not pretty, right? There was cruelty, there was stigma, even criminalization of HIV. And those things have long legs and give rise to many issues that continue to be part of our conversations. So the conversation tonight, about how to best serve HIV positive people is really important. The issues run deep, and you have a great panel, and I'm grateful to all of our panelists for being with us tonight. Thank you for your time and for sharing your wisdom. Look very much forward to hearing your discussion.
Thank you. Really briefly, I'd like to introduce our moderator, Matthew Skinner. Matthew Skinner is the Executive Director of the Richard C. Follia LGBTQ Commission of the New York State Courts, where he works closely with senior court system leadership in efforts to promote equal participation and access to the courts and legal profession by all persons, regardless of sexual orientation, gender identity, or gender expression. Prior to assuming his current position with the Office of Court Administration, he led the LGBT Bar Association and Foundation of Greater New York Legal for 4 years. He litigated at Proskauer Rose LLP and clerked for the Honorable Richard K. Eaton at the U.S. Court of International Trade. Skinner graduated magna cum laude from the University of Notre Dame in 2006 and Albany Law School in 2009. He was a member of the 2015 class of the National LGBT Bar Association's Best LGBT Lawyers Under 40 and received the 2019 Impact Award from Gay City News. Thank you, Matthew Skinner, so much for coming.
All right, thank you. Thank you so much, Michelle and Jessica, for inviting me tonight to moderate with this wonderful group of panelists. I'm going to quickly introduce the panelists, and we'll dive into the questions we are going to cover tonight. First, we have Diana DeGroat. She is a senior attorney and general practitioner at the Legal Aid Society of Northeastern New York in Albany. She has represented clients through Legal Aid's HIV/AIDS Law Consortium since 2014, and also works with Legal Aid's consumer and housing programs. She received her JD from the American University Washington College of Law, where she was a public interest public service scholar. Prior to law school, she was an international volunteer, serving as interim coordinator for a rural HIV/AIDS response program in South Africa. Welcome, Diane. Professor Joe Connors is a clinical professor of law for client interviewing and counseling and the director of the Health Law Clinic at Albany Law School. The in-house health law clinic has been designed to teach student interns how to identify and address legal issues that clients living with HIV face. He served as director of the Albany Law School Clinic and Justice Center from 2009 to 2012. He is the 2007 recipient of the Distinguished Excellence in Teaching and Distinguished Excellence in Service Awards at Albany Law School. He is also a recipient of the New York State ARC Robert Hodson Augustus Jacobs Disability Law Award. A former staff attorney at the Monroe County Legal Assistance Corporation, Professor Connor's research interests include preserving the integrity of families affected by health challenges and removing barriers to access to justice for individuals with disabilities. Professor Barry DeCoster is an associate professor of bioethics and philosophy at Albany College of Pharmacy and Health Sciences. His research interests focus on the areas of bioethics and philosophy of science and medicine and their overlap. For example, Dr. DeCoster is interested in how vulnerable patients, such as LGBTQ, racial minorities, and women, engage and respond to the particular needs of their communities. He's also interested in the lingering impact of the medicalization of LGBTQ health and how queer patients are themselves constructed as both ethical and epistemic agents. Dr. DeCoster received his BS in Biotechnology and Humanities from Worcester Polytechnic Institute, his MA in Philosophy from Michigan State, and his PhD in Philosophy from Michigan State. Jeff Hodeling is the program manager overseeing the testing program at Alliance for Positive Health. He has almost 6 years at the Alliance. He started as a community health specialist doing testing and case management with a focus on the MSM community. He was then promoted to a community health coordinator where he has had the same job duties, but then started to coordinate the testing program. Early this year, he was promoted to program manager, overseeing the testing program and data entry. He also still does some testing as needed, but most of his work is now supervisory. Finally, we have Perry Jungelis, who is the executive director at the Albany Damien Center. He is responsible for operation and direction of the not-for-profit AIDS service organization and has supported and increased a culture of empathy and trauma-informed approaches. He has worked to develop innovative HIV/AIDS prevention and care services for the 17 county regions of upstate New York and has researched, secured, and managed over $12.6 million in grant initiatives. He received his BS in finance from Siena and his MBA from the College of St. Rose. So thank you to all of our amazing panelists, and we're going to start with the legal questions. So I'll start with this question. What is unique about the attorney-client relationship with a client who is living with HIV? I guess Joe or Diane can jump in.
Sure, I'll give it a stab. Thanks, Matthew, and thanks, Michelle and Jessica, for organizing this. I think we have to be careful that we don't make generalizations. Every client is different. But I think there are some things that need to be considered, especially what's at stake. The interest in confidentiality and what can happen if there's a breach of confidentiality. Stigma that we're going to be talking about that still continues today. And the issues, housing, income, employment, and how all those affect health outcomes. So there's a lot at stake. So I think, of course, we should take every client's concern seriously, but these are especially important because things can turn pretty quickly without stable housing, income, or jobs. It can affect both physical and mental health. So that perspective is important. I think also when we're thinking about the attorney-client relationship, I think about trust, accessibility, knowledge, and leadership, and our special role as leaders, as attorneys, to make sure that services are available. And trust for a client living with HIV depends on having trust both in the client coming to you and you trusting the client too, and learning from the client. So it's a two-way street there. A lot of that, when I talk to my students in our health law clinic about this, is checking assumptions we're making, checking biases, having open discussions to make sure that we're not presenting ourselves in a way that's in any way judging. Instead, we're focusing on clients' goals. Accessibility, I think Diane can talk a little bit more about how extensive legal aids offices are in the region we serve. We serve over, I think it's 13 counties in Northeastern New York right now, but we need to be connected to the community. The location of our services has changed over time, but they've always been in a place where we can meet those with the greatest needs. They've always been connected to medical providers and social services providers, including the Alliance and the Damien Center. Accessibility also has to do with time. Things can change very quickly. So I guess being an HIV/AIDS lawyer, there is such a thing. I think a lot of times we practice in other areas as well, but being accessible and being ready to change direction on a moment's notice. Knowledge. I remember when I first started in this back in 1980 or 1990s, the early 1990s in Rochester. I didn't know a lot. I was worried about how I would be accepted by the HIV community. I did what I could to know the law, but the real knowledge had to come through relationships that I built with the stakeholders in the community. I spent a fair amount of time listening to radio programs like Homo Radio on WRPI to learn a little bit about the culture. I spent time going to HIV network meetings to learn the players. I haven't recently spent as much time as in the epidemic meetings, but I know Diane has, and she keeps me updated. But being connected is really important to be an effective AIDS law attorney. Having a certain degree of medical knowledge is important too, how the disease progresses, how it impacts an individual, both physically and mentally. Certainly in the Social Security context that both Diana and I do a lot of work on. We need to know the medicine so well that sometimes we're talking with doctors and say, hey, have you thought about this? Or we might see part of the big picture that they don't know about, and that might help affect getting good opinions that are going to help the client's cause. Leadership, I guess realizing that our role as attorneys is to help inspire others to pass it on, and we do that with the junior attorneys we work with and the students we work with, but also being aware of public policy issues and learning what we've learned to help other communities. Certainly, there's all sorts of lessons from the AIDS advocacy movement that are being applied by other disability groups now, and we need to keep passing on what we've learned to make a profession as a whole better. One final thought on that, and I'll let Diane chime in, is I think my own personal growth in this area is one from sometimes ego-driven, savior type lawyer to more partnership. So that's something we always have to keep in mind, always check ourselves. Our job isn't to save or change our clients' lives. It's to work with clients and help clients make decisions and access good public programs that are available to them and make the system work the way it should work in a fair and just manner. So I think that's maybe it's what all attorneys should do in all areas, but I think there are these special pressing needs that need to be considered as a HIV/AIDS law attorney. Diane, what do you think?
What if I just say second? I absolutely, on a number of those points, I think that for clients who are living with HIV, number one, and always number one, they are people first, and not their diagnosis first. And that is how you should always approach every single one of these clients when you are serving them. And you focus on that with what Joe was saying about having a client-centered approach to your advocacy. Your client is the one who defines their goals, right? And you are there to make sure that they are fully educated about their options and about their rights. As from what I have, observed in working with my clients is that having this diagnosis in many spheres it can feel like it's taking away a lot of power, right? And what we are trying to do is use the legal system and the legal tools that we have to put that back in their hands to the greatest extent that we can. Building rapport with clients who are HIV positive is critical because of what Joe was speaking about in terms of the really confidentiality critical in our field across the board. But the consequences for your clients who are HIV positive in the event that their diagnosis is disclosed without their permission can be huge. It can impact their employment, it can impact their housing, it can impact their family relationships, it can impact their social life. So we need to really understand those consequences and understand the law that is at play when we are looking at their rights in that area. So you got to know your law, right? You got to know your law, and you have to know your law in terms of how it is specialized for clients who are HIV positive. So for example, in New York State, we have Public Health Law, Article 27F. Perry and I can talk about it for hours, as can Joe. But if you're advocating for clients who are living with HIV, you want to make sure that you have that knowledge of some of the specialized laws that can be used to their advantage. And one of the other things that I think is foundational and that Joe touched on is, unlike with a lot of other clients, having some foundational basic knowledge of this medical condition and its diagnosis can really go far in building rapport with your clients and in advocating for them. Get your basic terms down, right? Have a basic understanding of what people are talking about when they say CD4, T cells, right? What my counts are, what my viral load is, whether someone is, what their medications are. It helps you have conversations with your clients in a way that helps you to build trust and to build the trust with them. Clients who are HIV positive are living longer than ever, which means that we are now seeing some clients who are coming to us who have been living with this diagnosis for decades. That comes with a history, and a history that if you get to know your client, you can really use it to your advantage when you're advocating for them. Keeping in mind that many of these clients, because they have lived with this disease through very dark times, which, early on in the epidemic, when there was a just blatant stigma and discrimination and a lot of loss and trauma. If you ever have the opportunity to learn a little bit about a trauma-centered approach to lawyering, and in any of your, your fields, your social services, I'm sure can speak to it particularly. It really helps you learn how to talk to your clients, how to understand when they're maybe not as forthcoming with you initially, or they didn't tell you something, that they're not trying to work against you, but that there can be history there and reasons there that it helps you to understand it and better communicate so that you can be a better advocate for them. And right now, I think it's important to talk a little bit about intersectionality, because we are seeing how race intersects with health, right? You're seeing how being a member of any other marginalized community, socioeconomic, being a member of the LGBTQ community, all of those things, as they intersect with a single client, can increase their vulnerability or increase their concerns in different areas. So having kind of an understanding of how those different things are interacting in their lives, to understand their needs and their goals as your advocate, it can really help you be effective in whatever area you're working in.
Thank you so much, Professor and Diane. Just following up on some of what you said, can you tell us a little bit more about the Health Law Clinic and also the HIV/AIDS Legal Consortium at the Legal Aid Society of Northeastern New York? What services do you all provide at the clinic and at the consortium?
Sure, we have a great partnership that's been going on for several years. A big shout out to the Department of Health, one of our funders through the AIDS Institute. The Health Law Clinic is a program where law students are learning how to be client-centered zealous advocates by representing real clients. So I work with about 8 students each semester to introduce them to new clients or existing clients. We've sort of have an informal agreement that the law school is focusing in on families affected by HIV or AIDS, whereas legal aid is having more individuals, although there are some. We represent individuals and legal aid will represent younger family members. So the types of cases include access to public benefits, Social Security, SSI benefits, going to hearings, appealing those decisions. Right now we have a couple appeals pending in federal court, one with which Michelle worked on when she was a student in the clinic. We also deal with Medicaid issues, going to fair hearings, making sure that the services that a treating physician feels are medically necessary are provided. There's often a big problem, especially in the area of home health care services, of clients not always getting the services they need. And there's a hearing process to challenge that. Sometimes we still run into problems with access to medications, either through Medicaid, Medicare, or private insurance programs. Sometimes somebody will have an additional medical problem, not HIV or AIDS, but we've had clients, for example, that need hepatitis drugs, but have been denied by Medicare. And we've had to challenge that denial. It was pretty crazy. A local provider said, well, because the patient is a recipient of a donor recipient and HIV positive, they're not entitled to this drug. That the FDA didn't approve it for that specific situation. And of course, the response was, well, that's not the way the FDA approval works. It doesn't say every appropriate use. It excludes inappropriate uses for drugs. But we had to go to a hearing, and luckily our close relationships with medical providers at Albany Medical Center and Whitney Young Health Center really help us in collaborating on those types of cases. We've also dealt with discrimination cases that I can talk more about as our discussion advances. There's still a lot of discrimination, and there's still a lot of families that are impacted in a way where the parent might be struggling with concerns and they're charged with neglect. We have to say, oh, no, this isn't a neglectful parent. This is a parent that needs some help in trying to fight for preventive services or working out family arrangements like kinship foster care. That is a special interest of mine, how that system is working. There's been some good advances that stem from courageous clients living with HIV that are willing to stand up for what's right, and it's made a big difference for other groups as well. So that's sort of what we do. Maybe Diane can talk a little bit more about what she does and some of the outreach and training that we do in the community as well.
Absolutely. So on the legal aid side of things, and we are a partnership with the Health Law Clinic, so we do referrals between our organizations. I handle very similar types of cases, and in addition to that, we also do outreach into the community and trainings, both for other service providers in terms of different types of legal issues, and for the client community so that they can learn about their rights. Why do we do it? I always think it's a kind of a fascinating thing. Like, why is the Department of Health funding a bunch of attorneys? And it really comes down to what you have probably heard in terms of the social determinants of health. So what we are talking about is that there are social elements that if there are problems there, people are going to have worse health outcomes. And a lot of those are tied to income, which could be, for example, loss of Social Security, termination from Social Security, applying and being denied. What's the remedy there? An appeal. Who could use some help with that from? A lawyer, right? Housing, unstable housing. When people's housing becomes, when they become homeless, when they are in unstable housing situations, there is very frequently problems with medical adherence, both going to medical appointments, picking up prescriptions, getting refills, doing the paperwork that's required so that they renew their insurance timely. So if we can keep people stably housed, then we can help them have better outcomes in terms of their health, including in terms of their HIV diagnosis and staying healthy in that realm. That means representation and eviction hearings, right? That means if someone is terminated, if their housing subsidy is terminated by Section 8, if they're kicked out from public housing, that is an appeal. And those are the types of legal issues that we can help with. We also do assistance with advanced planning documents. I think that this was there's a really big focus on this, particularly early on in the epidemic when people were really doing end-of-life planning. It was a reality that a lot of people needed to face. We are lucky, so lucky with the medical advances, but still for everyone, a good idea to have these documents in order. It can bring people, particularly people with chronic illness, some peace of mind, and having things in place if and when they need it in terms of their healthcare proxies, powers of attorneys, and wills. So that's another, type of assistance that we can provide through our programs.
I might just quickly jump in and say that the model is that legal services are a type of health service. Mm-hmm. That physicians can prescribe, you better see an attorney. And that's sort of the model that we have, working closely with the local medical providers. And I think in the end, it prevents future problems. It results in greater health outcomes. It actually saves a lot of money saves a lot of money. That's why the state, we're grateful for their support.
Yeah, when you can keep people out of emergency rooms because they are adhering to their regular preventative care, their regular medications, it is a huge money saver. And that frequently is one of the driving factors behind the funding. And that's okay because it gets the services into the community that the community needs.
Following up on those points, Professor and Diane, laws like the ADA and the Fair Housing Act protect individuals impacted by HIV and AIDS from discrimination with respect to employment and housing. We've known since the 1980s that HIV doesn't spread through casual contact and that spreading HIV is preventable, but stigma and discrimination are still pervasive. What do you think members of the legal field should be doing better to protect and support individuals living with HIV?
Being self-reflective here, which is an important part of being a good lawyer. I think focusing our outreach into the communities that are hardest hit is something that we need to continue to improve on. There's a lot of turnovers with case managers that we get a lot of our referrals for, so making sure we constantly go back and educate non-legal providers how to spot legal issues and make appropriate referrals. That's a big part of the problem. Pushing for ways for people to advance their rights without disclosing their identities. Like, there's probably more room we can do to push, yeah, there was discrimination here and this client wants to proceed as John Doe. We've had a couple of cases like that where the offending party really fought hard against that. One case where somebody wanted to go to a local cosmetology school and was denied because he was HIV positive. And a big issue became whether or not he could proceed under a pseudonym. So working in legal protections to allow somebody to advance their legal rights without publicly telling their whole story. I think also working and it's all an individual decision, right? If somebody doesn't want their status to be known, there's good reasons for that. But some folks step up and say, I don't mind, I want to do this as part of breaking down the stigma. So I think supporting those efforts as well, while not creating an expectation around that. So those are some things. Diane.
I think one thing we continue to do and can always do better is educating people about their rights so that they know that there is legal recourse when they've been violated. A lot of times people, like, they feel like something wrong happened, but they don't realize that there may be a legal remedy for it. And so they might not call. So they might not call legal aid. They might not call the health law clinic. They don't realize that there might be legal options for them. So the more we can get into the community to educate people about what their rights are so that they do call if something happens, I think that is a great benefit for people. I think individually, as attorneys, as human beings, we need to step up and interrupt stigma and discrimination if and when we see it. I will say, in my own personal practice, I have told people what I do, and I have been asked if I am scared to meet with my clients, right? That shows an ignorance about and a lack of education about HIV, the way it is transmitted, and that stigma about it still persists, despite how far we have come in this epidemic. And when that happens, it is an opportunity to educate someone. And so to be prepared, right, with that medical information that you didn't think you would need as a lawyer, to talk about, no, why do you ask? And to take that opportunity to explain that HIV, it is not transmitted casually. There are medications that people take that make it virtually impossible for them to transmit HIV to others. And, it is a very normal client relationship that we are able to have. And it really trying to educate about that. And Perry can probably speak about that so much more eloquently than I can. But that is something that I think we are all called upon when we are doing this work to step up and say something when we see it, because frequently the people who are victimized by it don't feel like they have a voice to do so. And the other thing I will pitch is, to the extent that programs can maintain HIV specific services, it really serves clients who are HIV positive better. I think that we have seen through the years, and again, Joe and Perry can speak to this better than I can, a lot of services that were specific to the HIV community starting to be wrapped into other, care for people with chronic illness, or, why should clients who are HIV positive with a housing issue, why do they need an HIV/AIDS law attorney as compared to a housing attorney? I will tell you exactly why. Because when they have a name and a face and a direct phone number to call, as compared to calling a general intake line where they have to disclose to some unknown person personal information that they're not ready to disclose, they are going to be more likely to access your services. There is data out there that shows that organizations have lost clients who are HIV positive from the community when they have tried to bring those services under other umbrellas. So to the extent that we can continue to tailor services to this community, to find the funding to do it, to keep these programs active, it's really how these clients, considering the confidentiality concerns, are best served.
Is there, we've got a little bit more time in this category of questions. Maybe I'll just throw to Perry and Jeff. Is there anything you guys wish lawyers knew more about folks living with HIV and AIDS?
Sure. So I'll give it a start and then pass it off to Jeff. Certainly, Diane hit on quite a few of the points about trying to get to know and build that trust factor. I think one of the things to recognize about people that are living with HIV and AIDS is that they have a lot of trauma in their backgrounds. And I think I see this with all persons who are, just by getting an HIV diagnosis, that is a traumatic experience. And so really understanding the trauma-informed approach is helpful to be able to validate a person where they're at and that they have experienced trauma, asking the questions of what happened, as opposed to, what's wrong with you? Sometimes just simple phrases can set off traumas with people, particularly with AIDS. So I think that that's always been one of the things that I've always found most powerful about working with persons living with AIDS, is really, understanding that there's a tremendous amount of trauma going on there, and oftentimes the issue they're coming in with is not the only issue of the day. There are most likely multiple issues that are going on. They're just here for that one crisis. That it might be eviction, it might be that they got fired, or it might be that they were discriminated, but that's just one of the issues on a mountain of issues that person is dealing with. So just having sort of that understanding, or to be able to say, yeah, this really is hard for you, it really does help to build that trust that both Diane and Joe have talked about. Jeff, I'll tag it over to you.
Those are some really good points. With stigma, one thing we have to really keep in mind, no matter who that client is working with or who that patient is working with, is, language. We just heard Perry say persons living with HIV, for example. So one of the very stigmatizing things about people who are living with HIV is being branded as HIV positive. And as one client I had said, I feel like I have a scarlet letter on me every time I have to disclose my status to somebody. So just, simply changing your language, not making assumptions, and to come free of bias and judgment will really go a very long way with every person that you work with who is living with HIV.
Thank you so much, Perry and Jeff. There's lots of overlap tonight, but we're going to switch to medical health questions now with Dr. DeCoster. We know that major scientific advances have been made in preventing and treating HIV. Approximately 1.2 million people in the US are living with HIV. Studies show that members of the LGBTQ plus community, especially Black, Latino, and transgender individuals, are disproportionately impacted. What do you believe needs to be done regarding the infrastructure of HIV care at a local, statewide, or national level to improve prevention strategies and help individuals who have been diagnosed?
Yeah, thanks for that question, and thanks for the invite tonight. I don't know, there's a bunch of things I've been thinking about with this. One is to kind of just pay attention to who's in the room when these decisions are being made, right? Like who are the people who are being impacted, the people who really need, who are on the receiving end of this care or the policy work development. Are they part of the room? Are they being supported correctly, appropriately? Do they have a voice in having say on how these systems are being set up? Diane, thank you for bringing up intersectionality, because I was thinking about this throughout all of this work. Right? It's kind of central to the way I've organized a lot of my philosophy and the way I was trained up in feminist theory. The thinking through how local positions for individuals matter and how we have to handle the details of this work, I think matters. So I see this with HIV. I see versions of this, right, and how at federal, state, and local levels we're even responding to COVID issues today, right? Are the people in the room who are going to be most profoundly impacted actually having a say? Do they want to say? I guess is one other question. But I think most people do. If they're not in the room, right, really asking why. So are they too busy? Are they handling too many other factors that they can't make it, right? Their day is too busy, or they don't feel safe. They don't feel invited. With HIV policy, I'm no longer in my 20s, right? So I'm now starting to see the world in slightly different ways. I'm starting to notice there are generations of people who probably would have been my mentors on a number of different things who just aren't here because they passed away years or decades ago, right? So there's the sort of lost energy and the development of policies, resources that could have been there had the pandemic not kind of taken their lives in certain ways. And so there's ways in which I'm still even noticing lingering impacts that are surprising me now in other ways. So I think there's this kind of work that is noticing that this is very much not the positive sort of these are the arguments we should be making for, right? But noticing what is shaping things, the assumptions we have, the invisible things shaping conversations we're having around HIV is part of the issue I've been thinking about. Also, I'm trained as a philosopher. I work at a pharmacy school, and when I took that job, I didn't know anything of, well, I would never have categorized myself as doing pharmacy work or public health work, but I landed in a public health program at a pharmacy school. And one of the things I've noticed is that public health as an avenue into approaching these with a focus on, say, prevention and sort of community understanding is really good and does a lot of work that is actually rather similar to much feminist work, starting saying, we need to think about the macroscopic and the microscopic, right? The community and the individual and their needs at both levels. And so when we're developing policies at any of those policy level states, where again, federal, state, community, really thinking through what are the needs of communities and individuals and attaining the goals for these policies. I think that's my answer for that question.
Sort of a current event topic here question. What have we learned from our response to HIV that you believe could be applied or is already being applied to the response to the COVID-19 pandemic?
Well, one thing that I guess I already knew, but it's becoming important in a different way, is that healthcare disparities aren't really taught well in medical schools, right? LGBTQ health specifically, I think on average gets something like 4 hours of curricular time in a standard, on an average in med schools across the country. And so some schools do it a little better, some do it less. My school is, in that sense, no better, no worse. I think we're probably actually a little worse on the sort of number of hours that we're actually spending on this. And so one is motivating the need, taking the space in a curriculum, right? To say this is central to providing good care. And what that means is you have to put it into lectures, and you have to put it ultimately on, you know, course exams, but on standardization exams, right? So when you're going up for accreditation, right, do accrediting bodies actually care about this issue? So trying to get work in that way. And so that matters again on, for queer folks, how we are given uptake in clinical settings, how providers are trained to deal with our unique situations. And that can be everything from very specific, you know, the importance of dealing with HIV, but also how to not stumble around pronouns in the clinic, right? How to make a patient feel comfortable. Those little things need to be taught. You're not born knowing these things. You may not pick it up in high school. And so you need to tell a young future clinician how to handle these things. And so that again means somebody has to take time in their course to handle these things. The other thing so those are some real basic things, right? Public health, if you do it well, is really good for everybody. And it ought not to ultimately be really worried as much about sort of individual communities. But when you do it well, those marginalized communities are raised up in a number of different ways. The other thing I've been thinking about a lot, though, is with COVID specifically, is some of the issues around confidentiality and handling the possible exposure to COVID. When HIV became, you know, a global pandemic or epidemic, we had to sort of create new tools. One of them that we handled was the practices of safe or safer sex, right? Those were new habits we had to write rules about, and we had to sort of think through what were your goals and sort of meeting with other people. There were moments where, I guess early, we were unclear about the virus's transmission. Once we understood it was through blood and sexual contact, we could create practices and teach those things, right? We had normalized safe sex. We taught it in schools. We normalized the use of condoms. We made it available to people who couldn't afford it. What I've been thinking mostly, though, about that as it's connected to COVID is, it's an old article in the Hastings Center report, and I wish I remembered. I probably could have looked it up. The author's last name is Ainsley, but he went through a history about the creation of the same-sex movement and how one of the critiques was sort of the over-reliance on the Tarasoff case in HIV, saying that you had a duty to, whether or not you had a duty to warn sexual partners, or whether or not clinicians had a duty to sort of step in and prevent harm. And his point there was to say, Tarasoff got used a little too quickly. The duty to warn language got used too early. Some people will have different goals around sexual encounters, right? Some are willing to put higher risk levels on this than others. And we haven't really had a good modern COVID conversation about that, right? What are the goals of socializing with others, right? And what are we willing to risk that makes sense in proportion to those risks? So even before we started recording today, right, I heard somebody was saying, they were making decisions about whether or not to go onto campus to teach. I've had to do the same thing. Making decisions about how we are exposing ourselves to students is one small thing, but we haven't had a really good community dialogue about saying what things are so important that we really should have in person, face-to-face, but protected conversations, and other times that Zoom really is the only appropriate thing. It seems like maybe America right now is trying to figure this out, 3 days before it happens around Thanksgiving travel. We should have been having this conversation months and months ago, as far as I can understand. But again, with the kind of negative or the gaps that I've noticed, one is that we don't really have venues for having these community dialogues that could shape individual decisions or really much better policy decisions on these things. So I think in that way, some of the masked debates have sort of gone off the rails in other ways. We really should be teaching people to say, what are the goals you want? You know, whether it's sexual goals, relationships in that way, relationships of seeing family, whether it be, you know, at Thanksgiving dinner, your family members who may be in a nursing home, right? How do we sort of say, if these are the goals, what are the risks and how are you willing to address those risks along the way to make informed decisions?
Perry, did you want to say something?
Yeah, if I was to unmute myself. Yeah, I think one of the things that the HIV experience has really taught us with the COVID, what we're going through now with COVID, is the contact tracing. And I think that the use of data and the use of contact tracing was something that was very early adopted by AIDS activists and also by the Department of Health through partner notification services. So that has really been an incredible tool with helping to stop the spread of HIV, especially in New York State. When someone does test positive for HIV, they are asked about potential other needle sharing or sex partners. And confidentially, they are able to contact those persons to let them know that they may need a test. Because we have seen over time is that HIV happens in clusters. Generally, you just don't get one HIV infection in a zip code or in a spot. There is a cluster that is connected to it. And if any of you have seen some of the old movies, you know, talking about patient zero with HIV, which has been disproved by now. But it was where they could really trace infections down to certain single sources. So I'm seeing this unfold with COVID and the use, especially in New York State, with looking at the positivity rates and also looking at where the clusters are. And it's just bringing back all the memories of what we are currently doing with HIV, but also how in the early days of the epidemic, we went after things. I think the other thing that is interesting with COVID, and one of the lessons that I really do hope we do learn through COVID, is that over time, as the medicines got better, a lot of people were able to take them on a regular basis and live. I'm one of those people. I've been living with AIDS now for 25 years. Back in the early days, there was an even playing field. Didn't matter if you were of white privilege, if you had a job, if you had connections, you were diagnosed with AIDS and you were given one option, you were probably going to die. As the medicines came out, slowly there became this divide where we saw persons that were suffering from the key social determinants of health, poverty, mental health illness, substance use disorder, became disproportionately affected by HIV. And I believe we're going to be seeing that also with COVID if we're not watching. Yes, people are able to make the choice, right, of whether to protect themselves, wear a mask, but there are going to be people who are not going to be able to make that choice, maybe because of poverty, maybe because of their mental health status, substance use issues, or maybe even traumas that they've experienced. So I think there are still lessons to be learned from HIV that we haven't necessarily adopted yet. And a part of that is we really are going to have to be looking at the most vulnerable in our community to ensure that we are providing them with the resources to be able to keep themselves safe. This became very apparent at the Albany Damien Center, where we provide non-medical services to hundreds of persons who are living with HIV and AIDS. Just asking them to wear a mask was not going to do it. We ended up having to put boxes of masks at every location so that even if they went to the other side of the building or even outside, when they lost the mask, they could pick up another one. So these were like just some of the ideas that we started to put into place to recognize that some people aren't going to keep track of a mask because they just are not able to. But how can we help them? So I think that there's even more lessons that we can learn from HIV, because the similarities between COVID and HIV, especially the early days, it's a little eerie. I got to tell you, for a lot of us long-timers living with AIDS, some of these things that are happening, it's scarily familiar. We're scarily going down a very similar path we went down at one point in time. And I think there's a lot of lessons to be learned from that.
Did anyone else want to jump in on that point before I move on? Go ahead, Jeff.
One thing I've noticed during this COVID pandemic is that there are still things, just like Perry said, that there's this great alignment, for better or for worse, of the HIV pandemic when it first started. And I'm realizing there are things that we still have to work on in the HIV branch of pandemic that we could apply to COVID. So, for example, mental health, the trauma of receiving a COVID diagnosis. You see it on the news now that X many people out of 5 are now suffering mental health and having mental health diagnoses just simply from having a COVID diagnosis. And the same thing with HIV, and we could still do that better with HIV. And then also the socioeconomic disparities and how Black and brown people are disproportionately affected. And not only affected, but also their health outcomes. So those are issues that we're still dealing with HIV that hopefully maybe with COVID can almost bring it back the other way and, help both sides. So I just want to throw that in there.
And maybe another.
If I may add, I
Go
just
ahead.
came out of a training earlier this week where the statistic was that Black and brown people are dying at a rate of 2 to 3 times more than white people. Dying, right? When we're talking about health outcomes. And when we revisit that idea of intersectionality, you can see how the vulnerabilities related to race, how that intersects with socioeconomic and what that means in terms of health outcomes. And we have certainly seen the same for people who are living with HIV. But I have sat on calls with Perry and a number of other individuals where people living with HIV are talking about how the trauma of going through that is really resurfacing. And I have certainly spoken with my own clients about that as well. Because not only are these clients immunocompromised by virtue of their HIV status. So this COVID pandemic is terrifying, right? But it is bringing up memories and experiences that really are impacting their ability to function sometimes in their daily lives, and keeping that at the forefront of our minds as we are still, trying to provide services to them in this environment.
If I could add one more thing, I'm thinking about another parallel is by some of the literature I've read, right? African American men who have sex with men or MSM or gay men, there's like a 50% likelihood that they will become HIV positive in their lifetime. And at this point, that I would say is we are past the period where we can't do anything, right? That is largely reflective. That statistic is largely reflective, not of the science around the disease, right, but about a social commitment or a political commitment to engaging people. We have PrEP, which is massively effective. Getting that out to communities is not going to be perfect, right? But it's going to be a lot better than 50% of, or letting 50% of people become HIV positive. With COVID, hopefully there will be a vaccine soon, right? But we know right now social distancing and masks work. But the problem may be that when it comes to something like a distribution system around a vaccine, right, there are still these sort of historical legacies of medical racism that are real and it's deep in the community. And we've done, I think we've done almost nothing effective to really eradicate that. And so there's this way in which I think maybe the parallels there, some of the sins of sort of addressing the HIV movement or HIV in certain communities, right? We haven't corrected some of these things. And I think in that way, it's again, not a science problem. It's deeply a social and political, maybe economic commitment, but we're past the sort of having excuses that we don't know how to fix it. We just haven't.
Yep. I'll jump in with a quick 30 seconds if you don't mind, Matt. It's working past the fear. It's learning from silence equals death. It's organizing. It's being active. We have the advantage of maybe less or a whole lot less stigma here, where there seems to be a willingness to respond in some way, but we need to do it with clear communication from our leaders based on what the science is. Also, I think looking at what the end point is and how we're going to measure that, and not think about a cure too soon, that there's lingering effects, and how we need to continue supports long-term for individuals. And definitely, I can't say enough the value of case managers and social support individuals for those who are being disproportionately impacted by this, and the value of peer support moving forward as well. Those are, I think, key lessons.
Thank you all. About 19 states, including New York, require people living with HIV to inform their sexual partners of their HIV positive status. Dr. DeCoster, what are the ethical implications of a mandatory reporting law like this?
I think one of the issues, right, it's probably not novel to anyone who's in the law, is what is the goal of such a policy? Are we trying to prevent future spread, or are we trying to somehow punish to go back and sort of retaliation for people who are living with HIV, right, and having aspects of their lives where it's spread? So I think one of the questions about that policy is really, what was the goal in setting that in place, and does that policy meet that goal? We had concepts, let's see, is this connected or not? Like, early days in the HIV epidemic, we said, though, there was the real stigma around HIV diagnoses. So we had the concept of HIV exceptionalism. And certain other moments, we protected names from being reported around HIV diagnoses because the stigma was so great. I think some of the movement now has been to say, well, HIV has entered a new era. The stigma has changed. Some of the prevention is different. So maybe HIV exceptionalism no longer holds here. We can treat HIV like we do other communicable diseases, and they're worthy of reporting. In that way, I don't know. I again think there was this goal ultimately to sort of track and normalize and see HIV in a different, safer concept. And I think that is a good goal, right? If we can kind of protect people and normalize, treat things in that way, moving away from HIV exceptionalism might be ultimately good for the entire community, quite frankly. But I do think that there was these moves with mandatory reporting. If we're doing that as a punishment system, I'd always be deeply, I guess, resistant or hesitant to thinking through, like, what is the point in supporting that approach? I think it would lead to greater hiding from testing systems, ultimately. It may be to my benefit not to be tested to see if I'm HIV positive, because if I don't know, I can't be held accountable for that. And that can't be the goal of good public health. And it shouldn't be that we should develop policies that ultimately work against these public health goals in that sense.
I'll just add to that, Matthew, if I could. Yeah, spot on. I think that was Barry, what you said about it being a disincentive, or to people getting tested, because truly, if you don't know you're HIV, if you've never had an HIV test in your head, you're HIV negative, and you could be living with HIV. But these laws, I mean, they might have had a good intent to try and stop the spread of the virus, but they are so incredibly misguided, because one of the things is, how are you going to prove this? Now, here I'm going to talk to a bunch of lawyers, right? Okay, so, let's talk about the most, common way we're all adults, right? That HIV is spread, unprotected sex. So, is it okay that am I going to need a notary public at the bedside to attest that I informed the person? Are they going to need to sign off that I actually informed them? To prove that I actually informed somebody? The ability for the abuses with this, first of all, are just insane. But also, how enforceable is something? This comes into a typical, he said, she said, yeah, I told them, yeah, I didn't tell them. So laws like this, just to me, absolute mess in the making. And it is truly criminalizing or stigmatizing further a disease that no one intends to spread, no one deserves to have, but it's a disease. It's so.
You framed it there. Sorry, Perry. Sorry, Diane. Do you want to go?
I just wanted to note that generally they don't have those laws for other sexually transmitted diseases, right? And that is why they are stigmatizing, because the way that HIV was treated in those situations, particularly as it has become a chronic illness as compared to a terminal illness, it has made it, and under many laws in many states, there are criminal consequences to doing something as an HIV positive person. And even as compared to having other sexually transmitted diseases. And that is, we do not practice criminal law, but there is a very big movement across the country to try to get rid of some of those laws. So certainly that is where that stigma comes in for those requirements and punishments related to some of those issues.
Looking at theories such as minority stress syndrome, can you explain the theory and how it interplays with people living with HIV in the LGBTQ plus community? Further, can you talk about what your research has shown and what kind of impact this has on healthcare, Dr. DeCoster?
Yeah, so minority stress syndrome, it comes out of clinical therapy models of trying to understand how to name, identify, and then ultimately quantify to somehow measure impact of, say, racism, homophobia, misogyny. And so when it comes to, like, say, queer lives, right, thinking through how we know that homophobia is not good for our mental health or bodily health, right? But it's hard to sort of pin that down into quantifiable moments. Somebody making a bad gay joke, at a bar isn't going to sort of ultimately be damaging in a sort of really clear sense in the way that we often talk about clinical exposure and sort of impact that way. So minority stress is ultimately a way of trying to think through how to quantify these things, how to name the sort of bodily impact that it takes on over, say, years, decades of these little harms. They're little paper cuts, right? They're little paper cuts, but over time, those paper cuts add up. And once in a while, one gets affected and it goes really badly. So if you can start to say minority stress syndrome, there are multiple models out there. One of the things I like about that is ultimately says, these social dimensions of health are measurable and they're interesting. And they're something that a clinician should take seriously when working with their patient, right? It says that there are bodily impacts on things like homophobia. One of the worries I always have about that, because I'm a philosopher and I have to sort of see something as good and bad, and that's just the norm, is what it means to start to quantify this stuff, right? To start to keep track. Like, why do we want to keep track of these things? Do we want things like this in our medical records? We haven't really talked about that a whole lot, right? But electronic medical records are a different beast in many ways than the old paper records where they kind of got lost or things got, little details disappeared. These records could follow us for a very long time. Minority stress also works with, like, again, this kind of trying to be productive and supportive of patients, but there are these kind of issues of ultimately medicalizing, I think, some of the putting the blame back on the patient themselves, right? Seeing the patient as the nexus of where the disease is experiencing, when what you're really trying to say is homophobia is immoral, and we should be putting more of the blame back on the person telling the joke in the first place, right? And so we're sort of looking for the harm here, and that sort of centers the problem again on queer bodies. So up until the early 70s, the United States saw homosexuality as a mental illness, right? It was listed in the Diagnostic Statistical Manual of Mental Illnesses. So around the same time we legalized abortion, we kicked homosexuality out of the DSM, and I've still been thinking about how people born today, right, are lingering with the impacts of that kind of medicalization. It's off technically the books of calling this, but we're still sort of working to, in that sense, I think, medicalize queer lives, and I think especially HIV. We're trying to sort of really understand the important balance queer people are trying to engage in of how much oversight we want our clinicians to have over our lives, right? We want engagement, we want support, but we don't want to sort of become only patients because we are queer, or getting the right balance of, again, is a really difficult challenge for us. So there's always the sort of skepticism for me about naming, having numbers and being recorded, and also, again, finding the right balance of how we want to engage doctors for the services we need, and be able to refuse when we don't want clinical oversight on certain things. It's hard to get into it. Once you're in a system, it's really hard to get out of those systems, is, I guess, another way of thinking about that. Right? We've battled a long time to get access, but I don't know that the LGBT community has really balanced or found a way to push back when we don't want unwanted or unnecessary clinical oversight or engagement.
All right, I'm going to switch to some community questions here for the service providers. In your experience, how have factors like gender, sexuality, socioeconomic status, and race played into a person's ability to prevent an HIV-positive diagnosis or to live with HIV after being diagnosed?
Sorry, trying to find the unmute button. So I'll go first, Jeff. So certainly we have the data that shows that there are key populations, right, when we're talking about the HIV pandemic. So men who have sex with men, especially Black and Hispanic, Latino, and Native American MSM, all persons of trans experience, women of color, injection drug users, and serodiscordant couples, which serodiscordant couples is where one part of the couple is HIV positive, the other is HIV negative. So these demographics in and of themselves don't necessarily put a person at a higher risk for HIV, but it's the contextual factors in which HIV occurs that are causing these key populations to be more impacted by HIV. The contextual factors go back to what Diane and everyone has talked about with the social determinants of health. When we're talking about poverty, when we're talking about inequality, mental health, geographic disadvantage, these all can place a person at a much higher risk of contracting HIV. And conversely, when someone does have HIV or is diagnosed with AIDS, it could certainly be a predictor of their health outcomes and their ability to be able to successfully manage the disease. A lot of it makes sense. If you don't have access to housing, to food, if you have to do sex work in order to survive, you're not going to have incredibly great health outcomes living with HIV. Systemic, someone, I think it was Jeff had mentioned, Black and brown communities absolutely experience still today health inequalities with accessing care. And also there's extreme mistrust of the medical community coming from Black and brown communities. And the movement now is calling to end this inequality. Mental health, including substance use disorder, are certainly areas that are going to predict if a person is going to be able to take their meds and survive HIV. And then, something we don't hear about a lot, geographic disadvantage. You're going to be more apt to contract HIV in an area that has a heavy concentration of HIV positive persons who are not virally suppressed than if you live in an area that doesn't have a lot of HIV positive persons. Okay, so I hate to tell you all, Albany has a high concentration of persons with HIV in it. So, in Albany, you're going to have a much higher chance than maybe, I'll pick on Essex County in New York, where there is not a high percentage of persons with HIV. But also, if you are living in a rural area and you have to travel for services, for support services, for HIV testing, I've known people to travel 2 hours on a bus to get to Albany Medical Center to get their treatment, because really, as persons with HIV or living with AIDS, you need to see someone who knows about HIV and AIDS. And they don't necessarily practice out in the rural areas. But so having to travel that far can be a detriment to your health with living with HIV. So yeah, that's my story. Jeff, I'll let you.
Yeah, that's really good, Perry. Thank you. When I work with my clients, so, as my intro had said, I was a tester, right? And I've tested, I think, like 900 people since I've been at the Alliance so far. And the grants that I had worked on focused on MSM. And we use MSM as a term very specifically as men who have sex with men, because not everybody who's MSM identifies as gay or bi. So you'll have a large population of men who identify as straight, who are afraid to come out and don't come out for a plethora of reasons. And they're having these activities on the side that are putting them at a much higher risk of HIV. And because of their stigma of, could be from culture, for example, like especially in the Black community, that they're not going to divulge these behaviors to their healthcare professionals who would otherwise do different testing or additional testing, so to speak. And, I see all the time people come in and, I had one client, let's use the parallel of HIV infections with rectal gonorrhea and chlamydia. We had a young guy come in, he identified as heterosexual. He came back with rectal gonorrhea. So even to us, a very open-minded agency, he could still not disclose all of his behaviors when he came in and got tested. So what I've seen, sexuality is a huge barrier, and being able to, you're coming out to your provider every time you're getting tested, and not everybody wants or is willing to do that. Yeah, so that's, one point I wanted to make there.
It's so interesting, Jeff. I just want to add to that. Just my experience over the years being a gay white male is that, before I tested positive, if I sneezed, had even a runny nose, right away they want to throw an HIV test because, oh my God, you're positive. A woman, and I could say a friend of mine who's a woman who was married, had every symptom of AIDS. Nobody thought to give her an HIV test. Turned out that finally someone, after she almost died, decided that maybe we should test her for AIDS. And so that's really hard sometimes when, people are presenting and right away we're almost making snap judgments of saying, well, you can't, because you don't really know. And it goes back to what Diane said. This is where you're developing that level of trust with someone. They can start sharing things with you that they don't share with their doctors, that they don't share with other community partners. That's going to give you a leg up in how you can really help them and really find out what's going on that is behind the scenes going to help you with, being able to serve them.
Right. And, with sexuality comes sex. So you can't talk about HIV without talking about sex. You can't, because that's its main mode of transfer, how. And, I even in my position, you know, I have no medical background, and I've gone to medical providers in the area and done training on how to speak to their clients about sex. I'm like, why are they not getting this in med school? You know, they might get their obligatory couple hours on a half a day to talk about sex, but it's not just talking about sex. It's who are you having sex with? What types of sex are you having? And what are you doing when you're having it? And then because sex is such a taboo topic, that just fuels the stigma for HIV, because in multiple different ways, not just because they came from sex, but if somebody has some kind of internalized homophobia, now they feel like every time they have sex, they're doing something sinful. And then on top of that, now they acquired an STI or HIV from it, and it just compounds it even more. So I think the root of stigma with HIV is about that it comes from sex, and we have to remember that.
Jeff, staying with you, the Alliance for Positive Health works toward ending the epidemic and eliminating stigma through its Undetected Equals Untransmittable campaign. Can you explain how U equals U and similar outreach initiatives reduce the stigma associated with HIV?
Yeah, undetectable equals untransmittable is a really interesting topic because it's something that healthcare providers working in the HIV field have known for a long time now. And the Department of Health, whether at the state level or the federal level, would refuse to endorse it because they didn't want to be the ones to say, U equals U, oh wait, somebody got HIV. So, but there's been so many studies out there now that just show beyond a doubt that, you know, U equals U is a real thing, assuming you're following certain criteria. You know, you've had an undetectable viral load for a certain amount of time. You know, that's its little caveat. So U equals U can reduce stigma, you know, going back to this law about criminalizing HIV, for example. Do you have to disclose your status if you're undetectable and now you can't give it to somebody else based on science? This is now a fact, not a medical opinion. So, you know, there's a new campaign that the New York State Department of Health came out with this year, which was prevention starts with treatment. You know, prevention starts with me, you know, going under treatment, becoming undetectable, so now you can't give it to somebody else. And just, you know, with the Department of Health and the CDC finally endorsing U equals U, I can't tell you how many people I've heard from how freeing it was, because now they feel like they can have sex again. Because they didn't want to be the quote unquote infected person or dirty person to have sex, and they just felt like they just couldn't be with somebody else. So it has actually been sexually freeing for the community, which is interesting how that now plays with the criminalizing laws there, which are obviously outdated. And I did want to make a comment about that law a while ago. We kind of had to move past it, but you know, we have to remember, you know, we say like, what was the purpose? You know, Barry's like, what was the purpose? And that's an excellent question. Obviously today it has no purpose other than being, you know, an a-hole law. But back in the day when we didn't know how this was being transmitted and people were scared, you know, we go back in that place in the early 80s where, you know, having HIV was a death sentence. You can see where these laws probably came from. But they're obviously severely outdated. And now we have U equals U, and knowing that treatment is so effective with HIV that it's a chronic condition now, that, you know, those laws should go away and the stigma will hopefully start to follow. But again, you know, there's still that stigma about sex in general. So that's a whole nother 8-hour symposium. Yeah.
The Damien Center and the Alliance for Positive Health are designed to provide community resources and support for HIV positive individuals and their families. This includes access to testing and PrEP, hot meals, nutrition education programs, pet care, support groups, and personal educational programs, among other things. Can you explain why establishing a local community support system is important to the well-being of people living with HIV?
Maybe I'll start this time. I found the mute button first. Okay. So, you know, Diane's point very early on in the symposium was talking about the layers that people come with HIV. It's not just their diagnosis, it's, you know, their income, their culture, You know, just those layers of onions. Everybody comes as an onion with all their layers. And oh my God, I forgot where I was going. It's 7:30. It's been a long day. And so we have to address all of these layers. Sometimes dealing with the diagnosis is not number one. So we have to have community programs that can easily reach these populations and build a trust with these populations to help address all of these barriers and all of these layers of onions that may come with their diagnosis. You know, housing, mental health, food. You know, if somebody doesn't know where their food is coming, you know, for tomorrow, the last thing they're going to worry about is taking their medication. Or if they don't have a place, you know, the lights on. So all these programs need to exist to keep somebody stably housed, stably fed, stably mentally, to be in a place where they can continue with their medication adherence and stay healthy.
So certainly the Damien Center and the Alliance, you know, for Positive Health, we've evolved over the years. And I think I made reference to this back in the day. It didn't matter, you know, if you were of privilege or not. You know, you had, you know, everybody was going to most likely die from this disease. And we saw it happening, you know, very rapidly. I saw it happening all around me. In fact, I was told I had 3 months to live. And I had no reason to doubt anybody because everybody was dying around me. The doctors were all telling me this. The caseworkers, I remember, you know, I remember getting my will done. That was one of the most important things. You had to get your will done. You had to figure out your healthcare proxy, who's going to make the decisions, you know, and you had to carry it on you too. You know, that was the other thing back in the day, you know, because, you know, you couldn't just hope that somebody was going to find it in a drawer or something. You always carried your healthcare proxy on you, especially for those of us with, you know, gay partners. But I think this is where, you know, our services have changed over time, because certainly if you're not living in poverty, if you don't have mental health issues, if you don't have substance abuse disorder, if you don't have trauma, if you're infected with HIV today, you're not going to necessarily need a ton of the supports that we provide. You're going to, yes, have a bit of an adjustment period, but the medicines are that good that you're going to be able to take the medicines and probably not even miss a day of work. The people that we're helping, and this is quite a few people, these are persons who really do have, as Jeff described, a lot of trouble getting to the medications, getting to their doctor's appointments because of housing, because of mental health, because of substance use disorder. That's where our community agencies are right now. And I can speak more to the Damien Center, but also I can probably, you know, for the Alliance too. We become, in the end of the day, a person's support system who did not have a support system before. We become their family when their family has disowned them or not understood or not been there for them. And trust me, today in 2020, it still happens that people disclose their status and they get kicked out of the family and said, don't ever come back. It still happens today. So we become that, and we become that really trusted partner. So, you know, at the Damien Center before COVID, we had the drop-in center where people would come in, you know, get support from one another. And still, it was where we were able to help a lot of people. But for some people, because of what they were going through, the traumas, the mental health, the substance use, they were not able to take the meds. For them, it was back in the 80s where we were just going to help them with the dying process, and we were going to make sure that they knew they weren't going to die alone. We just had one of our tenants pass away a couple weeks ago, and that was exactly what happened with this person. We were not able to get this person to be able to take their meds, and boy, I tell you, I pulled out every tool in my toolbox I pulled out to try and help, and to get the person, but the person was not in that space to be able to do that. They wanted to sort of live it up and go out with a bang. And you know what, that at the end of the day, that was that person's right to do. So we were there with them up until the end, you know, making sure that they knew they had a family, that they weren't alone. And so that in a big way is what our community-based organizations like the Alliance and the Damien Center are providing to people. And it's critical. I know one of the things, Matt, when you were describing, you mentioned the pet care program. So I get this sometimes. It's like, what you're providing, what does having a pet have to do with health? Well, for those of you who are pet lovers, okay, which I'm one of them, and I can speak from personal experience. I remember being very, very sick, and the one thing that was always at my side was my dog. And it gave me a tremendous amount of comfort. And for too many people with HIV, they're isolated. For them, I gotta tell you, for them, it's like COVID all the time. Even before COVID, it was like COVID, because they just disassociated and sort of stepped away from people because they didn't want to either contract something or, also, these are also persons oftentimes that society looks at as invisible. Very easy to see someone homeless on the street who's hungry and be able to walk right past the person. Well, that's usually our Damien Center person, everyone's walking past. But we really find now we have a lot of actual studies and science that has shown that owning a pet can increase your propensity for staying med adherent, for getting exercise, and for having less depression. These are things that all people with HIV and AIDS really absolutely can benefit from. So our PAUSE program, we help over 100 people. I think there's over 147 pets that we, make sure that the pets are healthy too, so that they can stay with their owners. And then, if a pet owner passes away, we're able to actually help the pet. I had one cat that went through 4 owners. This cat was made. I'm going back a little ways into the 90s. This cat was amazing. This cat outlived 4 people living with AIDS, but it kept being that somebody said, "Oh, I'll take the cat. I'll take the cat." So it ended up we just kept, as someone died, we would pass the cat to someone else. This cat was, something really beautiful, that this cat was able to provide so much comfort to so many people at a time when really, truly, they had no one else. So
I have written more than one will where the pet has been left to the Albany Damien Center PAUSE program. So at some point, Terry, there might be more coming in your direction. Hopefully not anytime soon.
Yeah, no, been there, we have a plan for that.
They're trusted, and it's a unique program, and it is one of the programs that provides the most comfort. Even I see it on my end, right? On the legal side of things.
Yeah, and no government funding, no, it's all fundraised dollars, so it's not an easy program, right, to, but again, we advocate, we advocate for the funding, we advocate for the services. I mean, really, and here I promised Matt to get back on topic, but one thing I wanted to say is that back in the day when we were advocating, we were fighting for our lives. We were fighting because we were scared to death of dying. We were sick of dying. We were pissed about all of our friends dying, and that's what drove us out into the streets. That's what drove us to be able to do so many of the things you may have read about with ACT UP, putting the giant condom over at Jesse Helms' house, doing the die-ins. But these are the things that got legislation passed and also got resources to help people. But a lot of it wasn't people in their day job kind of saying, oh, we should go help people. This was people living with AIDS, just terrified of the times that were going on. And so I still do today see that buzz in people. And so as I loved, Barry, when you talked about having people affected by the diseases at the table, it's so true. It has a different flavor, but also a different sense of passion and urgency, that it's not just that we need this program that we're talking about, it's that we absolutely demand it. We absolutely have to have it because no one else is speaking up for the people that we're talking about.
All right. According to the Albany Damien Center's 2018 report, the Albany Damien Center provided 20 permanent supportive housing apartments for 22 chronically unhoused people living with HIV and AIDS. Similarly, the Alliance for Positive Health provides financial assistance for things like moving expenses, household goods, and rental assistance subsidies, along with educational and skill building services. Can you explain how housing stability impacts people with HIV and AIDS and what the community can do to support programs like this?
So this really goes back to our onion. You know, if somebody doesn't have a roof over their head, they're not concerned about their diagnosis at this time. So again, the more stable we can get that client, the more likely they will be to continue with medication adherence, so take their medications, see their doctors, and have a healthier outcome.
So indeed, I mean, again, many studies shows that housing is healthcare. In fact, I would have to argue that housing is the first key step that anyone needs in order to access any other service that's out there regarding healthcare, regarding their medications. We work with a lot of people who are chronically homeless, who are actively homeless. So we do have housing. Our housing is usually always full. So there's always a waiting list. So there's usually a decent line of people waiting to get housing. And so they come to the Damien Center for services during the day when they cannot be in the shelters. And I can see, I can see why it's impossible. And we've tried a lot of different tricks, like we've had the meds there to be able to give people. But when you don't have a home, you don't have a place to put your meds. If you're getting robbed on a daily basis, or you're losing your jacket that had your meds in it, and you're most concerned about where you're going to sleep that night, is it going to be safe? Is it going to be dry? Am I going to be able to, get a meal out of the best dumpster in the city? Taking your meds is just not on the not on the radar there. So housing first. And what can you do? Well, I'll tell you, this is where we've got some huge disparities, even in New York State. In New York City, they have been fortunate with having assistance from the city of New York, but they have laws right now that are on the books that require that people with HIV only pay 30% of their income towards their rent. Now, this is only available in New York City. And this is, I want to say it's been 4 years now that they've had this law active on the books, that persons with HIV have been housed because of this law. And they have shown incredible progress with their rates of viral suppression. Viral suppression is a measure of the amount of virus in the body. It doesn't mean that you don't have any virus. I'm virally suppressed. I still have virus in my body, but I've got it suppressed to a really low level. And we also measure that from a community standpoint. So kind of seeing how many people in the community have an undetectable viral load or are virally suppressed. In New York City, they are showing higher viral suppression rates. In other words, people with HIV are doing better in New York City than the rest of the state. 75% of persons who are HIV positive live in New York City. 25% live in the rest of state and Long Island. Yet New York City, with their high concentration of people living with HIV, they're doing better. A part of it is because outside of New York City, there is not a law that is protecting us in upstate New York and Long Island, stating that we can only pay 30% of our income. There is a weak statute that says we do have to be housed, but unfortunately, the market rate for that hasn't kept up with the times. And we estimate there's probably, in the city of Albany, there's probably only 5 people that are housed out of a result of that. And I don't even want to know where the 5 people are living, because it's got to be someplace really, awful for what they're paying in rent right now. So what can you do? Absolutely advocacy. Advocating for us to have equal rights as even other people in the state. So, what we've been looking for as a while is to be treated the same as people are being treated in New York City who are living with HIV. The other thing is supporting the local organizations that are doing the housing, the Alliance, the Damien Center, and sometimes it's not just financially. Sometimes it is with our advocacy on all levels. There are so many ways to get involved to be able to help us, because one of the things right now, I'll tell you, we are facing a fight with what's called 340B. the New York State budget has enacted a change that is going to essentially take money away from providers like the Damien Center to help shore up Medicaid. It's called the 340B Medicaid carve-out. And we're fighting this. And it's set to start on April 1st, and it's going to affect our housing program because a lot of the money that we receive from 340B is used to help support our housing program. It's also help for meals. It's also help for providing support. But the state has decided, granted, the state is, having, financial issues right now. COVID's a big unknown, but we are arguing the wrong way to try and shore up Medicaid by taking from the safety net providers. So certainly at the Albany Damien Center website, www.albanydamiencenter.org, there's lots of great information. Just got to give a plug there about the 340B fight. We actually have a website called Save the Net, where you can automatically send a letter that goes to your representative, also to the governor, the Department of Health, Division of Budget, to call for the carve out. So that's, what can be done. There's quite a bit. We've just got to, we said before, we have the science, right? Today we have the science. 1980, we didn't have the science. 1990, we didn't even have the science. Today we have the science. What we've got to do is overcome the racism, the homophobia, the systemic poverty issues, and we just need to have the will to get this done. And sometimes it is where we just have to stand up and fight and advocate for people.
All right, you sort of jumped into the last sort of official question, so I'm going to transition now to, I think, the more wide open Q&A. Michelle sent me one question she's already got. I encourage people to use the chat room to send questions, and we have about 15 minutes left. We'll see if we can get to some questions. The one that I've got is there's a general perception that younger generations are more aware of inclusivity. However, do you think the remoteness to the darkest days of the HIV epidemic has taken away from younger generations' awareness of traumas faced by people living with HIV? Maybe I'll go to Perry first, who's shaking his head.
Yeah, I'll give you a brief. Back in the day, one of the best prevention methods or messages that we had was to keep yourself safe and to be knowledgeable about HIV was watching everyone around you die. And it was horrific. This generation today does not have that. And I'm thankful for that, because that is why we work so hard. We work so hard as a community, as a nation, to bring these medical advances forward and to be able to get a lot of these services. I am so thrilled that we have a generation that is not seeing all of their friends pass away. But I think that's where I get concerned also, because I don't know if we're having these conversations and really saying that HIV is a real thing. And it also, the HIV today is not the HIV of a number of years ago. The HIV of today is resistant to a number of medications. Also, HIV does not come by itself. It's got a number of drinking buddies, other Hep C, gonorrhea, syphilis is big in the area. Big combination there. So my worry is that we're just not having these conversations enough. But I feel very glad that this generation is not, that for them, Ryan White, this period of time is more of a history lesson rather than a lived experience. Like someone my age, it was a lived experience. I can still see their faces. I can still see the funerals that we went to, sometimes one after another in the same day, that I would be going to and speaking at. I'm glad that they don't have that experience right now.
Maybe in a similar vein, this is just a question that came to my mind, maybe somewhat similar. Some of the great HIV storytellers died this year. I'm thinking of Larry Kramer, Terrence McNally. What do you think the sort of next generation of HIV storytellers, what is the story that they need to tell, how did the arts play an important role in telling the story of HIV? I don't know if anyone has any thoughts about that, but I was just huge fans of both of the work of those guys, and I've been thinking about how we pass the torch to a new generation of storytellers.
I envision their story to be the day HIV was cured. I mean, we could already start passing the torch by talking about how we can prevent HIV with 1 pill a day. And, soon it's going to be easier than that. You get a shot in the arm and you're good for 3 months. But with that torch is going to become the rise of the STIs in the late 20-teens and early 2020s. Like Perry said, young folk are not seeing their friends die. So caution to the wind. Now we have social media. We've got these hookup apps now. So everything is compounding. And I think the stories now are going to be about how they don't know anybody who didn't have chlamydia by the time they were 25. But I would hope to see soon in the future that there will be some kind of cure. Right now, the way to prevent HIV with Truvada or Descovy now, and then soon the injectable, I think that's going to be in the storybooks.
Part of the way we can handle stories too is how we have, sorry, Diane, I keep cutting you off. How we respond to people, the little narratives, the social cues, the narratives we have. I was thinking back a year or so ago, a student came into my office, somebody I've known for 4 years, and done work study in our department. It's a health science school, they're all bright. And he came into my office one day and he shut the door. He's like, Dr. DeCoster, can I talk to you? And I was convinced something bad had happened, somebody had died, or I don't know, he was in trouble with the law or something like that. And so we sit down and he sort of stammers through it and he's like, can you help me find somebody so I can get on PrEP? I'm like, sure. I didn't know where this conversation was going, but that wasn't what I was expecting given the tone he was setting, right? And so it was kind of I gave him the information I had and the contacts, and I'd had somebody come in just a month before to a class, and so I got her. Within 24 hours, he was all set, right? But one of the things I tried to notice on that was just my own reaction of whatever the somber thing was, this kid was really trying to take charge of his sexual health, and that should have been celebrated, right? He was doing a very adult thing and being very careful and cautious. So no, I didn't have the other STI conversations with him, but I was proud of him for this, right? And so I try to leave it on a kind of more upbeat note. And I think that might be one of the things we have to sort of continue to think through is what it means to sort of really take seriously the rituals around these conversations. And it's about addressing shame, but not directly, or it's a backwards way into some of these issues. My pleasure.
I know that for me, I hope to see a world where a person living with HIV can be open about their status and not live in fear. And I think that is where a lot of the tools that we have as a legal profession can keep trying to move that forward. And as I have grown up in my advocacy, and as someone who is coming to this cause as a member of the newer generation, it is making sure we don't drop the ball and that we move it forward. Right, and keeping that passion alive and telling those stories and elevating those stories. And I do have to jump off this call because I have an 18-month-old who is way past his bedtime. But on that note of stories, what I wanted to emphasize to all of the law students and practitioners who are on this call is that that's what your clients come to you with. They come to you with a story. In law school, they come to you with something you're supposed to pull issue spotting out of and find the legal problem and analyze it so that you get to the answer. That is in the practice. What is in between those lines is just as important to serving that client well, because that is how you understand their goals and keep them at the center of your advocacy. So listen to those stories. Don't just listen to those stories for the legal cues, because there are many, many other elements there that are going to make you a better, stronger, more effective advocate, and to be able to keep this cause moving forward, because the people that came before us did such an extraordinary job at such a great personal sacrifice. So that is my pitch, my last remark. And I just wanted to thank all of you at the law school for, keeping, you don't see a lot of panels like this sometimes anymore, and for really bringing us together. So hope you have a good conversation for the last 5 or 10 minutes as well.
Thank you so much, Diane.
You're welcome. Thank you.
Bye, Dan.
One other question I got was for people who want to continue this conversation and continue learning, do you have recommendations for books, articles, podcasts, etc., for more information about HIV?
There are some really incredible books that are out there that can tell the history of HIV, and The Band Played On is one. They can be a little bit of a difficult read, but also in a lot of ways very inspiring. Of course, there are some movies too. Some of you may have seen, like, of course, I'm going to forget the one with Matthew McConaughey in it. The Dallas Buyers Club.
Yeah.
These are true stories. I remember people that went to Mexico to go get these drug cocktails and came back and sold them. These are a lot of these are true stories. So there are some incredible books, but also there are some incredible publications. POZ magazine, P-O-Z magazine is one. They have an online version, but also a print one that is printed monthly that talks about issues specifically to HIV. Also, Positively Aware. That's another one that's easily accessed. And then also keeping in touch with the Alliance and the Damien Center. We have mailing lists, and quite often we are sending out information about things that are happening. Yes, we do send out information about the fundraisers, but also we send information about how people can get involved, and also when there's changes with that. So there are some, I'm probably forgetting a few, all the books are all the great books of the history are escaping me right now.
I was thinking, I normally live in New York City. In the last few years, there was just all the great AIDS plays for whatever reason got sort of revived on Broadway. So Angels in America, Torch Song Trilogy. There you go.
Yeah, Body Counts. This is, Sean Strub. He's back in the day, he would put his lab work on. He would share his lab work publicly to kind of show people his journey. And this is just, incredible. Again, real story. Of people who were, a lot of people, and this just ties back to one of your comments about, who are the next storytellers. A lot of people like Larry Kramer, one great example, they didn't set out to become storytellers. They didn't set out to become like, these persons that are, it's just they saw a moment and they took charge, and they took, and they advocated for people. I'll never forget meeting Jeannie White, who was Ryan White's mother. Ryan White, if you don't know, he was a teenager who back in the early 80s was denied going to school because he contracted HIV through a blood transfusion. Jeannie White she was amazing. She was like, I said, my God, incredible to meet you. And she said, no, she's like, I'm just a mother who lost her son. You're the ones that are doing the work. And it struck me at that moment that, yes, Jeannie White, Ryan White, we talk about it, the past that they forged and everything. At the end of the day, this was just a mom that wanted to see her son go to school. And she fought for it, and he fought for it. And then a lot of people rallied around and they fought, And now there's a federal funding package, the Ryan White dollars that are named after them. That's how story makers are made.
I put some link to a great legal resources in the chat box, so you can check that out. I think the challenge to the law students is telling the story, where we're at now, what the virus is, and how we can use the lessons learned to fight the new virus, right? There's so much to be gained from the experience of organizing, of compassion, of the role of peer support, of the role of community involvement, the role of learning how to listen, that we can apply to the new virus to move forward. A lot of people died, and I don't think their deaths were in vain if we can carry that message forward.
So somebody asked about storytelling and brought up podcasts. I just make a slight challenge, given the ubiquity of podcasts these days, right? So the list Perry went through, like that's a great reading list, and it's amazing. It's important for the HIV history in one sense, but it's also in some ways a very narrow description. It's often, most of those stories are about white men's experiences in urban settings. Podcasts are so easy. So about 2-3 years ago, I made a challenge to myself. I deleted all my podcasts that were hosted by straight white men. So they were all gone. And like actively look out listen as you're listening to that, start listening to what they recommend, and branch out to podcasts hosted by only women of color, right? They don't let boys on. Like, dive into that stuff. Dive into podcasts that are different maybe than the community, because there are other stories there, and it's kind of fast. I feel like I'm 1,000 years old, right? But it's like the way in which people are expressing those stories are out there. You just need to be able to sort of take the sort of moment to look for them, and then you can weave and just follow these great conversations that are about people who are doing really different kinds of activism, facing really different challenges. And the great thing about podcasts is most of them are free, right? So you just have to kind of do 2 minutes of searching and click, and then spend your time just listening to other people's lives. So another recommendation.
Great note to end on. Michelle and Jessica, I didn't know if you wanted to say anything else before we call it a night.
I just want to say thank you to everyone. I feel like I've learned so much tonight, and I really appreciate you giving us your time.
I echo that. Thank you. Thank you to everybody who shared information and stories and strategies tonight. It was really a great evening.
I know this was recorded, and maybe if you could let people know where the recording might be available. Maybe I'm assuming the law school might make it publicly available. So stay tuned to check your emails on that if you're interested in a recording of this.
Yeah, absolutely. We'll work on sending that around. Thank you everyone so much for your time. This has been fantastic. We really appreciate your expertise.
Happy Thanksgiving to everybody, whatever that might mean this year. Be safe.
Yep.
Thanks everyone so much.
Thank you for having me.
Thank you guys.
Good night.
Right.